I know that Sarah Caney did a very good webinar on kidney disease in cats and talked quite a lot about the IRIS guidelines. So we'll see how that poll goes. Unfortunately, and I do get told off by a couple of the vets, it doesn't work on iPads, the polling, but do feel free to tap yes or no into the question box if that is the case. So we've had 64% of people voting. Just give people a couple of more seconds. I know there will be a few new people or people who don't come on very often from Nick's lab, from clients from Nick's lab. So you're all very welcome coming along as well. And basically, you should just be able to click on yes or no on the poll question to answer it. So I think that's probably about enough time. We have 38% say yes they do, and 62% say no they don't. So I'm sure you're going to bring that all in and teach us something.
That's very helpful to know. Thank you very much. Okay, one of the reasons that I wanted to talk about chronic kidney disease is that I think this is an area of veterinary medicine that certainly over my time in practice has developed enormously, and it's turned from being a very bad news story, having chronic kidney disease, to essentially a really pretty good news story in many cases. And part of that is because we've developed a whole background of knowledge and information. Partly we do a lot more testing than we used to do, and that's allowing us to pick up kidney disease at a much earlier stage. So it's unusual for a pathologist to have a good news story to tell you, but I hope that you'll see by the end of this evening that I think there's a lot of good things have happened in this particular area. So briefly you can see that these are the kind of areas that I want to cover. Just a quick introduction into kidney function, first of all, just very briefly to review kidney disease, and then a little discussion about IRIS, this International Renal Interest Society that has produced guidelines to help us to both monitor and treat cases of renal disease in a kind of logical and evidence-based manner. And then I'm going to move on to talk about the tests that are used in IRIS to get to that point. I want to make some points about phosphate, because it seems to me that that's often overlooked. Briefly, if we have time, to talk a little bit about some key concepts in urinalysis, and then round that off by looking at how you can kind of combine that into an IRIS profile to monitor and treat your cases. So to kick off with, please don't strain your eyes trying to read the captions on here. I'm sorry, I don't know why this didn't scan very well, but just very briefly, just to remind ourselves of what the renal functional unit is in terms of the individual nephrons which comprise the kidney. And that within each nephron we have an afferent blood supply that feeds into the glomerulus, encased in the Bowman's capsule, and there's an efferent blood supply that then passes on to terminate in the renal vein, and in the meantime forms part of the counter-current mechanism that we see in the renal medulla, which allows the establishment of a very concentrated environment of ions in that area to allow urine to be concentrated. So between the afferent and efferent blood vessels there's a blood pressure difference, and that's what actually drives the formation of the glomerular filtrate, and that filtrate then passes down the proximal tubule in the renal cortex, passes down into the renal medulla through the loop of Henle, that hairpin-shaped structure, and then on out into the distal convoluted tubule, and then to the collecting duct. So that's the kind of anatomy. Functionally, again, don't strain your eyes on this one. I think the important points to remember are that the renal fluid that starts off, the glomerular filtrate, is comprised essentially of an ultrafiltrated plasma. And by that, what I mean is that high pressure that we talked about, that pressure that we talked about within the glomerulus, squeezes fluid and small molecules that are small enough to pass through the basement membrane within the glomerulus, squeezing between those specialized renal cells. And this filtrate then very quickly, as it's passed into the proximal tubule, starts to be modified. So it starts off simply as a filtrate, and then we see processes of modification that are going on at all levels within the kidney. So first of all, in the proximal tubule, we'll see a reabsorption of a lot of molecules that the body wishes to retain, things like bicarbonate, glucose, amino acids, and phosphate to some extent. And then we can see as the filtrate then progresses down into the renal medulla through the loop of Henle, we see a sort of two-stage process. First of all, a water permeable loop heading down, so water can pass out of the tubular fluid into this very concentrated medium we were talking about outside. And then in the ascending loop, this part of the loop is impermeable to water. Water can't leave it, it's trapped in there. And in the meantime, we have a number of mechanisms that will pump ions out of that filtrate, that now modified filtrate, and allow adaptation of the contents so that homeostasis can be maintained. Because the kidney not only is involved in the excretion of nitrogenous waste, but it's also involved in acid-base regulation, total body water regulation, and obviously the maintenance of internal homeostasis by the maintenance of ions that we require to retain. And so we end up through this second phase after the loop of Henle, which is really almost a continuation with the distal tubule and the collecting duct, with a whole bunch of mechanisms which are moving ions to and fro in order to maintain homeostasis, many of which are under endocrine control. So we see here the actions of aldosterone in terms of the retention of sodium, and we see the actions of PTH in terms of moving phosphorus in and out of the glomerular filtrate, so that we end up with the urine that the body is excreting full of the things that it doesn't want, like urea and potassium and phosphate and ammonia. That's all lost, and we retain the bits that we actually require to hang on to. So that's in the normal physiological state. But obviously, when we start to think of chronic kidney disease, all of these mechanisms are at risk, and this is a critical function, life-critical function, and therefore, when kidney failure develops, then very quickly we can see significant morbidity and mortality. When we think of chronic kidney disease as an insidious and progressive disease, regardless of its underlying etiology, once we're into chronic kidney disease, it will progress inexorably. But the good news story is that we really developed mechanisms now changing the rate at which that progression develops, and quite often our patients can now live long enough to find something else to die of kind of in the interim. So we have a variety of different causes of chronic kidney disease in origin, and we'll look at some of those in a moment. But once the process of disease is established, it's insidious and progressive, and it will progress ultimately, but we can modify that. And what we tend to find is that there are local intrarenal changes that are compensating for what's happening within the kidney as the glomerular filtration rate declines. And glomerular filtration rate is a term for that process of extraction of ions and molecules from plasma and pouring those over into that first glomerular filtrate. It's like a fraction, if you like, of each individual compound that's actually removed, and that's how we measure it. Looking at those intrarenal changes that compensate as glomerular filtration rate declines, and also now recognizing there are systemic consequences of renal disease, things like hypertension and of renal secondary hyperparathyroidism, and seeing how, if we can adjust those, we can actually significantly affect that morbidity and mortality. So very briefly to talk about the causes of chronic kidney disease, we have the inherited nephropathies, the conditions that you're sort of familiar with probably in terms of polycystic kidney disease in Persians. We have the effectively resulting in a kind of structural change within the kidney that results in abnormal function. We have the glomerular nephropathies, where the target organism or the target of disease is essentially the glomerular membrane, and that glomerular membrane, which is normally a very sensitive filter, becomes increasingly less and less selective as to what molecules can actually pass through, and so we see more and more protein passing through into the urine. And then we have other, and perhaps less common, things that we sometimes see, things like tubular deficits, where the absorption process, the process of the body taking back things that it requires from the filtrate, is defective. A classic example of that will be Fanconi syndrome in the Pursengi. Now, there are a lot of these are recognized, and it's difficult to keep tabs of them all. So I use the database that I mentioned there, so that if you have an unusual breed coming to you and you think it might be congenital, have a look on that and see what they're saying about it. Acquired renal disease, by far the most common form that we see, and often we cannot identify what the initiating cause was. All of these things that I've listed there have been suggested in terms of drugs, infection, toxins, and trauma. Renal damage can also be associated with systemic disease. If you think of leptospirosis, for example, that's essentially a systemic disease, or FIP, which can also damage the kidneys, is essentially a systemic disease, and the kidney can be involved in that situation. And glomerulonephritis and renal amyloidosis, those are examples of diseases which can develop, again, because there's inflammation or immune-mediated disease going on somewhere else that gets filtered out and then damage the glomeruli. And the link I've put at the bottom of this slide just gives you an article, a brief article that sort of talks about the factors which can affect renal disease or the development of renal disease in the first instance. And they talk about in man predisposition factors, initiating factors, things like infection and diabetes mellitus would be two common ones. Progression factors that again would relate to recurrent infection or hypertension, and again diabetes and other endocrine disease. And then end-stage factors, factors that really bring life to an end at that stage. So, as I mentioned, you can see that the histopathology here of chronic kidney disease is very non-specific. It's just developing fibrosis with an inflammatory infiltrate and the replacement of these normal tubular structures, which is the actual renal tubules at that level. And renal biopsy at that level often won't tell you really what the underlying cause was. So, as I mentioned, what's changed? Well, when I started, and Anthony unkindly reminded me that I've now been at this for 30 years, basically, when I was starting in practice, the cases of kidney disease that I saw tended to look like this top Siamese, emaciated, depressed, and really at the end of the road before we'd even started. It was a disease with a very poor outlook. And this little guy at the bottom, another Siamese, and he's also got chronic kidney disease, but he's an example of where we are now in terms of management. And the things that have really changed is that we understand the pathogenesis much better. We have tools for earlier diagnosis, and we can now kind of manage those systemic effects, these things like hypertension and hyperparathyroidism that drive further progression of the renal disease. And I think that's very valuable. And we also have some useful tools therapeutically. We've got good renal diets. We've got great drugs, things like ACE inhibitors. And we also have these protocols to help us, and IRIS is one of those. So this is just the link to give you a bit of information about IRIS for those of you who are not using it at the moment. Its central tenet is that you run a series of diagnostic tests, some of which are based on blood, but an important one of which is blood pressure. And from the results of these tests, we can actually accurately stage the disease for an individual patient. And more importantly, from that once we have a stage, we can devise a therapeutic plan which is standardized and which has got an evidence base to support it. So the essence of IRIS is that in fact we monitor renal disease and we define renal disease on the serum creatinine concentration. We'll talk a little bit more about that in a minute. And then we bolt on additional substages dependent on the result of how much proteinuria is going on. The greater the proteinuria, the greater the risk that the animal is going to more quickly progress into renal disease. And we also substage dependent on blood pressure, because that's another good predictor of likely organ damage, which can occur both in the kidney and elsewhere. And it's something that we want to manage. And IRIS will kind of give you the tools to be able to manage that effectively. And the last criteria that's included in IRIS, which is critically important, is phosphate, and that we basically have to keep an eye on, because it is of itself deleterious to the patient in terms of the fact that they feel they just don't feel well if they've actually got a high phosphate. But more importantly, it triggers some secondary endocrine changes, which are, again, further deleterious to renal function. So that's the aim of IRIS, is to kind of give you a programmed system for investigation and therapy for those people who are not using it at the moment. And I think if you look at the list of people who've been involved in it, it reads like a who's who of renal investigators and clinicians, and I think this is well based. It's not, although it's sponsored by Novartis, it's completely independent, and I think has stood the test of time very well. Okay, so this is just an example of using IRIS in relation to creatinine, and essentially what we have is 4 stages that we talk about, and we'll start from top to bottom. So if the creatinine is increased greater than 100 micromoles per litre, we need first of all to find out whether the patient has got any pre-renal or post-renal factors. That means pre-renal means things that happen before the level of the kidney that affect renal function, and post-renal meaning things that affect renal function after the level of the kidney. We need to make sure that none of those are having a bearing, and we'll talk about those. But classic pre-renal issue, I guess, would be dehydration. And if that's present, we need to correct that before we try and stage these patients. But assuming the patients, we can rule those out. If we're in a renal azotemia, in other words, an increased creatinine and urea associated with renal disease, we can stage that to some extent dependent on the extent of the increase in the concentration, and then sub-stage it with additional steps, and then institute our therapy based on that. So when we're at this higher level of creatinine, it's easy to see, are we talking renal, if we can exclude these pre-renal and post-renal factors. At lower creatinine concentrations, which actually span the normal, sit on either side of the normal range, and that's one of the things we're going to talk about, is how we use normal ranges these days against these kind of criteria. We can see that basically we're in a range where we're trying to determine if the increased creatinine is associated with kidney disease or not. And one of the key things that helps us to make that differentiation is, can the animal still concentrate its urine? In other words, can it produce a high urine-specific gravity? And you can see that the algorithm there will kind of guide you that if the urine-specific gravity is high, then we have to suspect that this again is a pre-renal change. There's something before the level of the kidney. The kidney itself is trying to function okay, but there's something else affecting renal flow, renal blood flow, and we need to correct that in the first instance. If the animal is unable to concentrate its urine, it would imply that there is some renal disease present, and because we've got a relatively minor increase in creatinine, that would be graded as a stage 2. And the last thing which might be new to you is the idea that we can still have kidney disease present even though there's no azotemia at all, and that's stage 1 disease, and we'll talk about how that can come about. So essentially what we're looking at is this track progression from a nice normal healthy kidney here to this end-stage kidney, and what's happening during that process. And we're losing renal function because we're losing nephrons. We've got these compensatory responses that the kidney is managing to try and maintain function, but which in the longer term could be deleterious. And we've got some systemic changes, things like hypertension and renal secondary hyperparathyroidism, that again are going to damage the kidney further. If we look at that progression then from a fully normal kidney, this is the kind of equivalent of that healthy kidney we had at the top of the picture, to the end-stage kidney here at the other end. During this time, we're going to see a progressive loss of renal function, and usually trying to survive with less than 5% of renal function is a no-go. We're really into terminal renal failure at that stage. But ahead of that, and from the progression of normal, you can see first of all that you can have an awful lot of damage to the kidney. We can lose more than 50% of the renal functional mass, and effectively we can pick up nothing with our routinely available tests of urinalysis and urine-specific gravity, and urea and creatinine. That's what we're referring to in UN and CRT. And it's only really when we're moving to 2/3 loss of renal functional mass that we start to see some changes. And in the dog and usually in the cat, the first change that we see is this loss of ability to concentrate the urine as much as in a normal individual. And because we're losing that ability to concentrate, the urine volume starts to increase. And we may be able to pick up at that level that there's a mild polydipsia present.
Nick,
yeah.
Could I just butt in for a second? I'm hearing you fine. We've got 3 or 4 people who are saying that you're quite quiet. Could you put your mic, your microphone up a little bit, just see if that helps them? There's not many, but there's 2 or 3 that seem to be.
I'm not honestly sure where I adjust that, if I'm honest with you.
Have you got a headset on?
Yeah, yeah.
There may be a little thing on the headset that you can actually just increase the sound a bit. We can't see this thing when we want to. Just see if that will go up a little bit more. Let's try that and just see if that helps people. Sorry to disturb you.
No, not at all. No. Is that any? Well.
Yeah, we'll see how they get on. We'll see how they get on with
okay,
that. Thank you.
Fine. All right. Okay. Let me just back up there for a second.
Right at the bottom, Nick, I can see it. It's the, yeah, you've got it, great.
Yeah, great. Okay, so as we see this progression into renal failure, the first thing we lose is concentrating ability, and then when we get to about 3/4 functional mass loss, around 75%, that's the point at which we start to see the creatinine and urea coming out of the reference range. During this initial phase, though, we will still see that urea and creatinine are creeping up, but they're usually within the reference range. This grey area here you can see is the reference interval. But it's not until we lose 3/4 of the kidney that we actually start to see what we term an azotemia, an increase in urea and creatinine that we can actually detect. So this is why when we were looking at that earlier staging, when we see urea and creatinine starting to increase, and we're starting to lose concentrating ability, which is reflected here with increased polyuria, then we know we're into actual renal disease. And obviously as time goes on, you can see that the creatinine and urea increases are fairly slow, even though we're losing a lot more kidney, and then suddenly there's an expansion or a marked increase in urea and creatinine concentrations right towards the end of this viability point at 5%. So this is what's called a curvilinear kind of pattern of progression. And in one sense, it can scare us because we can find very high values, and we are assuming this is terrible renal disease. But in fact, lower values are not that much better in terms of the renal function. But if we can claw the animal back to that slightly better position, it's going to do much better for the future. So when we're actually trying to monitor these changes in terms of iris, they essentially take exactly the same view. They're taking normal urea and creatinine first of all to sort of say, well, we've still got 100% of our kidney mass loss, 100% of our renal function. We're starting from there, and so our creatinine is normal. When we're down to 66% of renal function having been lost, that's the stage when we're going to start to see reduced concentrating ability, but we're still not necessarily azotemic at this level. That's what they term stage 2. And about halfway through here, we're moving into overt renal failure, as we would have classically described it, azotemic renal failure. And then by the time we're getting to higher and higher stages, we find the stage will move up to stage 3 and eventually to stage 4. So effectively, the stages in iris mirror really what we've just been looking at there, and they're defined by the creatinine concentrations, and you can see how they define those terms. And the numbers will vary a little bit depending on whether we're talking about dogs or cats, but we'll look at that in a second. So why does renal disease always progress? Maybe it's because they have repeated insults. Maybe it's because of these, and most likely it's because of these maladaptive responses, normal physiological responses that actually become damaging to the patient in the longer term in terms of secondary hyperparathyroidism and glomerular hypertension and filtration. So when we talk about the tests that we're going to use, obviously we have a number of options, and I'm just going to basically concentrate tonight on biochemistry and urinalysis. We just have a word or two on the others. What tests do we need to run? Well, these would be our kind of standard panel for renal disease, and we'll look at those in a little bit more detail. So creatinine, first of all, I'm going to concentrate on creatinine because that's what's used in iris rather than urea this time around. It's a very simple progression, really, or a very simple molecule to understand. It's formed from the breakdown of muscle compounds that are involved in energy production. That's creatine and creatine phosphate, excreted into the blood, and the blood concentration is simply a consequence of the amount of creatinine that's coming in versus the excretion that's going on through the kidney. There's a very small amount that's lost through the GI tract, but the vast majority of the excretion of creatinine is through the kidney. So the concentration in blood in many ways simply reflects how well the kidney is actually able to filter the creatinine out. But as we've mentioned, the actual excretion can be influenced by these pre-renal, renal, and post-renal factors. So we'll just have a quick look at those. There are also just very slight and mild non-renal factors that affect creatinine. We've said that creatinine is released from muscle mass, so if we either have a great deal of muscle, as we do in an athletic breed, then sometimes you'll find the serum creatinine will be slightly high. You've probably seen that in boxers and greyhounds would be the two that would come to mind with that. You can see a very slight variation with creatine intake. If animals are eating high meat meals, then maybe there's a very slight effect there. But these are usually mild, and usually you don't even see anything. It's just encompassed within the reference interval. But the renal factors that affect creatinine, you will see pre-renal changes that will affect creatinine. And what we mean, as I mentioned, with a pre-renal factor is something that reduces blood volume, so renal blood flow is reduced. Dehydration, shock, cardiac insufficiency, hemorrhage, all of those where there's reduced blood pressure, all of those will result in a pre-renal change. Nothing wrong with the kidneys, it's just the volume of fluid going through the kidney. Addison's would be another important example, and quite often when you're presented with a renal patient, just remind yourself, should I be thinking about Addison's here, and at the very least checking the basal cortisol or an ACTH stimulation test. When we're thinking about how do we differentiate between pre-renal changes and proper renal disease, if you like, there can be multifactorial things going on, and I'll show you an example of that in a minute. But basically we go back to the history and physical exam, check the urine specific gravity and see if there's retained concentrating ability. And we can also look at the ratio between urea and creatinine. That can be helpful. I'll show you that in a second too. There's a fairly consistent ratio that we see in normal individuals, and if that ratio is disrupted, then that gives us a clue we've got a pre-renal factor there. But sometimes it's still hard to tell, and sometimes you just need to take serial samples to see whether the azotemia persists. So here's a case, 7-year-old Cavalier King Charles. These are the parameters we measured, these are the results, the units, and that's our reference intervals down here, and you can see that the abnormal ones are flagged. And Toby was already on treatment. He's a Cavalier, so obviously he has mitral insufficiency, and he's on drug therapy for that with diuretics and ACE inhibitors. And then he had just a bad weekend and was anorexic and was vomiting somewhat. And these were his results on initial presentation. And you can see here that we have a moderate increase in creatinine, but the increase in urea is basically higher in proportion to the creatinine. There's typically a kind of 10-to-1 ratio between creatinine and urea. In other words, the urea value is typically about a tenth of creatinine. So we would have been expecting here in the normal course of events to see, if this was just a renal change, that we'd expecting to see a urea of about 31 or 30 there or thereabouts. But here you can see the urea is higher, and that's a clue that we're likely to have a pre-renal change going on here. And in this case, just physical examination told you that Toby was dehydrated, and the history told you that he was likely to be hemoconcentrated, and his drug therapy wasn't going to be helping either. And in this particular case, when we checked his urine-specific gravity was low. It was about 10-20. So he did have some underlying renal disease, and superimposed on top of that was some pre-renal changes as well. And often we find we're dealing with these multiple issues. Okay. If we think about the renal factors that affect creatinine, well, these are all the things that are going to produce the renal damage that we've talked about. So things like toxins, inflammation, necrosis, it could be vascular infarcts. All of the things that basically essentially cause renal disease are the renal factors. And the post-renal factors are things like urinary tract obstruction and rupture, where we get leakage of urine or retention of urine. So the kidney is working normally, but the waste products can't be lost, and so they're reabsorbed into the circulation, and we see a marked azotemia at that level. Now, the blood tests that you run will not differentiate post-renal changes from renal changes. That's really down to clinical evaluation again, and it's important to bear that in mind, particularly if you have an acute onset renal failure, particularly after trauma. Then certainly be thinking about urinary tract leakage at that level. We do see from time to time animals with uroperitoneum. So creatinine is a good test because it meets our normal criteria for a blood test. It's stable, it's economical, it's easy to assay. It correlates well with glomerular filtration rate and therefore with the renal functional status, and it's good for monitoring. We can monitor creatinine even within the reference interval. The downside of creatinine, as we've mentioned, is we're not going to pick up increases until we're 3/4 of the way into renal failure. And sometimes people, when I'm chatting to them, will sort of say, oh, well, I don't think, there's not much renal failure here. The creatinine's only a little bit increased. Well, you have to bear in mind it's not a little bit. It's already lost 3/4 of its functional mass at that level. So it's time for action, really, as soon as we pick up mild changes. I'm not going to go into urea just in depth because of the limitations of time. But I would make the point here that urea, which is also excreted by the kidney, is formed from nitrogen breakdown products, which are then processed by the liver and end up as the molecule of urea, principally from ammonia. And because they're formed in this way, and they're not an endogenous product like muscle breakdown, they're a bit more subject to different external influences, like how much protein has been ingested, whether there's been a gastrointestinal hemorrhage. And it also is affected a bit more by reabsorption within the renal tubules and within the kidney itself. If blood volume is low, we'll actually see water and urea being reabsorbed. And as a result of this, we can sometimes see situations where we have an increase in urea that are not associated with renal disease. And these are called the so-called false positives. And we also have that same issue of, if you like, the false negatives that we still won't necessarily see a rise in urea until we've lost 3/4 of renal function. So it's a good assay. It's the most sensitive assay that we have for kidney failure. That's why you probably use it in your screens from that point of view. But it is subject to additional influences that you don't see with creatinine. And that's why creatinine is used in IRIS. So that's just a kind of summary of those two, both useful tests. But I think one of the most important things that I found with urea is that it correlates with the clinical status of the patient. How's the patient feeling? And you'll get the best indication from that from what the urea concentration is. And how are the kidneys doing? The best test for that is actually the creatinine concentration. So let's look at how we actually use these in day-to-day work. So this is kind of welcome to my world. This is a screen print from the system that we use here at the lab. And you can see that in a conventional system, we would have, just as we talked about before, the results, the units, and in these two yellow columns here, you can actually see the reference intervals for each of the parameters that we're looking at here. And you can see in this screen that was taken of a cat that was being monitored for its treatment of hyperthyroidism, urea is just within the reference interval and creatinine is mildly increased. And T4 seems to suggest we have good control. So with old Tabitha here, you'd be inclined, I think, often you would sort of think, well, I don't see that much here, but the creatinine's up a little bit. Maybe there's something going on there. Maybe there's something not. But because there could be a slight pre-renal factor going on there. But you know, I think many people wouldn't particularly flag that up. But what I think I would recommend now, where we're living in a world where we take multiple samples from the same individual, you can see that at the flick of a button, we can now simply look at all of Tabitha's blood tests, and in this case it's going back to 2009. And when we do that, we gain some useful additional information. We can first of all see the track of her original hyperthyroidism being well controlled there. And you can see as an illustration here, when she was first presented, she was very thin and therefore low skeletal muscle mass, and therefore her creatinine was low. And that then gradually came up. And that has continued to increase. And this is a classic example of where we're crossing over in stage 2 under IRIS from a normal creatinine concentration to an increased creatinine concentration within that same band. And that's happening before we're actually getting to the stage. We can see very easily here the progression of renal disease actually over a longer period of time. It becomes much clearer when you look at these results sequentially. And of course, we have that question of, well, could there be a pre-renal factor affecting that creatinine? Well, if we look at her total proteins, we can see her protein, in fact, has come down on this latest sample. There's no suggestion here that she was dehydrated. So we're going to take that result more seriously, and hopefully we're going to act on it from there. So this is the kind of newer approach to interpretation of lab data, where we're actually saying, A, we're going to look at some clinical decision limits which are set within the reference interval, and B, we're going to sequentially look at our patients so we get a lot more information. And if you don't have a lab system that can do this easily within your practice, then I think it's something that you need to look at as to how you achieve that. As I say, we do it routinely in the lab here, and I'm sure most of the other labs would have similar systems in order to achieve that. But it will give you a lot more information for your money, and I think that's we certainly gain more by doing that. So we've talked about these kind of criteria for defining non-azotemic renal failure in stage 1, where they then become mildly azotemic, and then moderately so, and then severely so. And I think quite reasonably you're probably going to say to me, Nick, it's 4 o'clock on a Wednesday afternoon, I'm not going to remember these numbers. That's quite reasonable. And IRIS, fortunately, on their website, print you off these kind of cards that will very quickly give you something where you can just look at a creatinine concentration and pin it exactly as to where it is on the chart. And these charts will also apply to the other criteria, things like proteinuria and blood pressure measurement as well. So it's actually quite a simple system to use. So let's talk briefly about phosphorus. And phosphorus is critical in renal failure, and so we just have to take a little detour to look at how phosphorus actually is managed within the body. And essentially, the serum concentration is the balance of intestinal absorption, which is under endocrine control from parathyroid hormone, and or 125 dihydrocholocalciferol, or calcitriol, vitamin D3, that is. It's also influenced by bone mobilization, so where the bone's being broken down. It's influenced also by the translocation of potassium molecules into and out of cells. And it's also obviously influenced by renal excretion, and renal excretion is regulated by PTH. So in the normal animal, we have a situation where we have all of these influences, intestinal absorption, influenced obviously by the amount of phosphate that's being consumed, but under endocrine control in terms of vitamin D. We have bone breakdown, which is regulated both by vitamin D and by PTH. We sometimes have these translocation effects, and certainly in diabetes you probably notice that they often have hyperphosphatemia, simply because the insulin is not there to allow the phosphate into cells. And then we have renal excretion, which is influenced by PTH. And those hormones themselves are actually regulated by a number of factors. There's a kind of reciprocal arrangement between vitamin D and parathyroid hormone, and both hormones are also influenced by the ionized calcium concentration. So we have a kind of complex regulatory arrangement between these two hormones in order to maintain phosphate and calcium. And principally it's calcium that's being regulated, but the net effect is that phosphate is regulated at the same time. So when we look at what happens in kidney disease, as we mentioned, glomerular filtration rate goes down, there are fewer nephrons, we've seen all that scarring, and the nephrons that are left are not necessarily working very well, and the ability to get rid of phosphorus, which we usually have an excess of, is reduced. So phosphorus concentrations go up. And phosphorus, the rise in phosphorus concentration switches off the enzyme that results in vitamin D, the active form of vitamin D being produced, vitamin D3, the 125 dihydrocholecalciferol. And as a consequence of that, with a reduced level of vitamin D, there's less absorption of calcium from the intestine. So the ionized calcium, the free calcium, the FCA, and there declines. Now, the reduction in ionized calcium and free calcium has two effects. It stimulates the further release of PTH, and PTH will then try and compensate for low calcium by basically getting bone to break down and therefore release more calcium, and it will also encourage absorption of calcium from the intestine as well. So there's a kind of mechanism of regulation, whereas as the ionized calcium falls, PTH kicks in order to try and restore the ionized calcium. And at the same time, it will promote more phosphate excretion through the kidneys. But as we've said, the kidneys are not necessarily in a very good position to be able to promote that, but they do compensate to some extent. And at the same time, the increase in PTH will switch on this enzyme back on again in order to produce the more active form of vitamin D3. And the net effect of all of these changes is that we'll find that everything appears to be in normal limits with the exception of the increase in PTH. And what we learned over the years, and going back to this idea that pathogenesis is so important, is that that increase in PTH is extremely damaging to the kidney and also damaging to the systemic circulation. And we'll look at what it has systemic effects as well. And so management of PTH and trying to limit the increase in PTH, principally by limiting this increase in phosphate, is absolutely central to managing these cases. So if we look at what happens over time, this is another way of looking at our declining glomerular filtration rate, our renal function, just as we looked at in these other charts, and the early compensated phase and then developing additional renal changes and then going into frank renal failure. We find that phosphate is moving up and down, usually within the reference range at this stage, just fluctuating up and down. The vitamin D is dropping down and then being pulled back up as the enzyme which produces its production is upregulated by the fall in ionized calcium and increased PTH. And the ionized calcium is fluctuating up and down as well, but again within the normal range. But the one that we can pick up is that increase in PTH. Now eventually the kidney runs out of compensatory ability, and we'll find then that phosphate starts to rise, vitamin D tends to drop, ionized calcium starts to drop, and PTH becomes very high very quickly. So why does all this matter? Because the hyperphosphatemia is directly toxic to the kidney. It adds to that damage and progression phase, and it's also associated with hyperparathyroidism, big increases in PTH. And we also get to a point where there's so much phosphate in the circulation, there's a risk of metastatic calcification. Metastatic calcification is simply precipitation of minerals that can go on anywhere. It can go in the gastric mucosa, it can happen in the lungs, but it can also happen in the kidney. Here it is in the kidney, this black material with metastatic calcification. And you can see how damaging that would be to an already damaged kidney. And the other thing that we've learned in the last few years is that the increase in hyperparathyroidism triggered by that increase in phosphate itself is directly damaging to the kidney and has these other consequences right the way through the systemic circulation, including CNS depression and the animal feeling just systemically unwell simply as a consequence of the high levels of PTH. So one of the lessons of the last 20 years has been if we can manage phosphate and PTH, then we will significantly help the patient. So the tools of the trade there, as you all well know, are diet and more recently phosphate binders, and certainly in the US principally directly supplementing with vitamin D in order that we can then get that reciprocal relationship and get those PTH concentrations back down. But if you're going to be using calcitriol, you need to keep monitoring the PTH. So the IRIS approach is fairly conservative in this sense, and it aims simply to make sure that we limit the extent of the increase in phosphate. So these are the reference intervals that we have for dogs and cats, and these are their target values. And this is a very important area to consider, because particularly when you're looking at cats and you're measuring phosphate, you now have to consider not just, am I outside the reference range? You've now got to think, I'm in the reference range, but I'm at the right level for the stage of renal disease where I want to be. In other words, it's critical that we measure phosphate every time that we actually have to deal with this, every time we're dealing with cases of renal insufficiency. And not only that, we have to make sure where are these values. Normal is not just within the normal range is not good enough. We've actually got to get this down to the appropriate level within renal disease itself. And you can see that as the stage of renal disease becomes more advanced, then we have to accept that there will be some increase in phosphate. But basically, we have to accept that phosphate will increase to some extent, but we do have to be aware of the fact that the more we can limit this, the more we're going to help the patient. And I think one of the take-homes I'd have from tonight is if you're not routinely measuring phosphate, that's absolutely critical for these cases now. And does it make a difference? Well, absolutely, yes, it does. This is looking at survival. This is looking at a group of cats which were actually on control diet and then on a renal failure diet. And you can see that the incidence of mortality if we do nothing to manage phosphate is very high over this 2-year period. And you can see that if we actually can control phosphate, then the outcome for the patient is significantly improved. The 2-year survival is greater than 50%. Calcitriol therapy, just a word on that. Some of you may be starting to think about using that. It certainly looks on an evidence-based basis that this is a random controlled clinical trial that the mortality was significantly reduced with the therapy. So I think that's something that we should at least consider. IRIS recommends that at stages 3 and 4 disease in selected individuals, but it is expensive because you have to keep measuring PTH, and it's not a terribly easy hormone to measure. A word about potassium. I think just for time I'm going to skip forward a little bit on that and just show you a case example. We can see in renal disease both too much potassium, and certainly if you have a persistent hyperkalemia, that's usually not considered to be a good prognostic sign in kidney disease. Once you're losing the ability to excrete potassium, then you're approaching an end stage of renal disease. But we also sometimes see low potassiums, and that's as a consequence of high kidney flow rates associated with that polydipsia and polyuria. And this is a case in a cat where they've got quite profound hypokalemia going on, and there's a bad effect on renal function at that level. And it's interesting because although the hypokalemia is a consequence of the presence of renal failure, it's also true that if potassium is low, it makes the renal failure worse. So there's a kind of feeding loop there, and it just makes it important that we measure potassium routinely when we're actually looking at renal cases. So high renal tubular flow promotes potassium loss, and potassium depletion is not terribly well reflected in the serum concentration. Some people will say, again, if you've got a potassium certainly of less than 4, then you should be thinking about actually potassium supplementing, because it's difficult to tell whether they're really depleted with that. And hypokalemia will make renal insufficiency worse. And hypokalemia in some cases, I mean, all of the clinical signs described here can all relate to renal failure. Some of these cases probably are actually at least in part, a consequence of hyperkalemia there. And as I mentioned, if you're seeing persistent hyperkalemia in chronic renal failure cases, that's a bad prognostic sign. Just a word about hematology, just to make you aware that you certainly can see anemia and it can be clinically significant, but the reason I want to do hematology is it can provide a bit of information about the nature of the renal changes. We can certainly see anemia, which is associated with chronic renal disease, and as soon as you see that, you know the renal changes have been there for some time, and I think it's well worth checking the hematocrit and seeing where we are. And we can gain additional information by looking at the red cells. We will see increased variation in the shape of the red cells, that's poikilocytosis, in chronic renal insufficiency. And when the hematocrit becomes significantly reduced, the anemia itself can be contributory to the signs. So it can be of some prognostic information to us because it can tell us that this has been going on for a while and that it's severe. So this is poikilocytosis. This is just the Greek word for meaning irregularly shaped, and you can see these red cells. Some of them are nice and round, and some of them are regularly spiculated, and those we term echinocytes. These are Burr cells. That's another variant which is called a keratocyte. But these are just variant forms of a damaged red cell membrane associated with uremic toxins, essentially. The other reason for doing hematology is that it might give us a clue as to the nature of the renal disease. We might see changes like these, which are inflammatory changes. This is a band neutrophil with a DOLE inclusion. It's a toxic cell, and basically this is associated with the presence of active inflammation and potentially infection. This is its precursor. This is a metamyelocyte with sort of fat sausage nucleus here. So if we're seeing these changes, then we're thinking about inflammation. This, on the other hand, this is from a dog, and we can see this is an atypical lymphocyte with a nucleolus present in the nucleus there. That might give us a clue we're dealing with neoplasia, and we need to go looking for that. So it's well worth doing hematology, but this is not something you're going to be able to necessarily pick up on the numbers. You have to look at the morphology of the cells here to gain this information. So urinalysis, very briefly. The golden rules kind of thing, it's essential for the identification of pre-renal azotemia. It's important for assessing proteinuria, and it can help us to determine sometimes between acute and chronic disease, and it's critical for the identification of bacterial infection. So specific gravity we would really mention. Our benchmarks are that if the urine-specific gravity is high, then we can be sure that we've got a pre-renal change and that renal function is still okay, underlying renal function is still okay. If we see a urine-specific gravity in the range 1.008 to 1.012, then we are in the isosthenuric range, that's called. It's the same concentration as, or same specific gravity as the glomerular filtrate. In other words, the kidney is unable to concentrate or dilute the urine at all. That's an indication that we're definitely in renal failure if that's a consistent finding. And if we find a low urine-specific gravity, i.e. 1.000 to 1.006, interestingly, that implies that renal function is okay. It takes quite a lot of work from the kidney in order to dilute the glomerular filtrate to that level, and it implies that underlying renal function is actually adequate at that level. So it's the range, the 1.008 to 0.012, that is the footprint, if you like, of severe renal disease. And obviously there's a progression, as we've seen with everything else, as animals gradually lose their concentrating ability. Just a word about cats. We say that a urine SG of greater than 1035 usually would exclude renal disease. Well, not quite true in all cats. Remember, they're desert animals, so they're very good at retaining water, and you will see the odd animal that will actually have a high urine-specific gravity greater than 1035, but it's in fact in renal failure. And there you really need to just monitor the blood biochemistry and look for azotemia, and if that's consistent, then that would point you in the direction of renal failure. Remember also that cat urine-specific gravity should be read on a different scale. They actually don't compare exactly with dog urine SGs. So ideally you'll have a dual read instrument for that. Do not use the dipstick scale on specific gravity sticks. They're not reliable for animal species. So proteinuria, very important, because proteinuria has again now been recognized to be a risk factor for the progression of renal disease. So if we can manage proteinuria well, if we can limit it, we will slow down the progression of renal disease. And when we find an animal is proteinuric on a dipstick, these are the kind of things that we need to be thinking about. How severe is it? where is it coming from, is it persistent or is it a transient change, and could it be an artifact? And the artifactual kind of causes of proteinuria are either if the pH is extremely alkaline, the alkaline pH will overwhelm the buffers which are in the stick, and you find that you get a colour reaction as a consequence of that. It could be if you've left the stick sitting in the urine for a long time and the buffers again have been washed out, you may get a colour reaction there. If the sticks themselves have been exposed to quaternary ammonium compounds, disinfectants, and then you find they can be effective and you'll end up getting a positive reaction when it's not present. So that's the artifacts you need to be aware of. When we think of normal values for proteinuria, well, we've mentioned that in most situations we use the urine protein creatinine ratio to determine this. And this is simply the ratio between the amount of protein that's excreted in the urine and the urine creatinine concentration. And we use urine concentration, or we use urine creatinine as a marker of how concentrated the urine is. As we've said, usually the rate of creatinine excretion is pretty constant, so we can use that as a constant and compare that with the amount of protein that's coming through. And usually the actual amounts of protein that are emerging are very low. As you can see on this slide, only 2 milligrams per deciliter or 20 milligrams per liter. It's not very much protein at all that's actually there. And when we find an increase in protein, the issues really are, where's that coming from? Is it because the glomerulus is damaged and there's more leakage going on? Is it because the renal tubules can't reabsorb any protein as it's coming through? Or is it because there is lower urinary tract disease and inflammation going on further down in the bladder? So the first thing we have to do is kind of localize where that change is going on, and we'll talk about how we do that in a second. But we do find serial measurement of urine protein creatinine ratio helpful for monitoring our renal cases, and it does have prognostic information as well. So those are the kind of values that you're looking for. We'll just move forward because it seems that time is moving on us. Basically, when you get a dipstick positive first time round, the first thing to do when you see that is to say to the client, we're going to have to monitor this because you cannot make the call just on a one-off urine sample. The first thing that we need to do is allow for these kind of transient problems that can go on, where if an animal is pyrexic, for example, you'll find it'll have a mild proteinuria. And we need to document persistence. And the second thing we need to do is to get our urine sample by cystocentesis, so we're avoiding the presence of any urine, any contributory factors of protein coming into the urine as a consequence of lower urinary tract disease, be it cystitis or a fallopropucial discharge or something in a voided sample. We need to get a good cysto sample. And if we find that the proteinuria is persistent despite that, the second critical thing we have to do is look at the urine sediment. If we see an active sediment, that is that there are inflammatory cells present in the urine, then the first thing we have to do is rule out urinary tract infection and actually assess whether the proteinuria is persistent after that. If we look at the urine sediment and we find it's inactive, in other words, there's nothing there that we can find to explain why the urine protein is there, we're starting to infer that this protein is coming from the kidney itself, and it's either from the glomerulus or from the renal tubular absorption, or usually a combination of the two. And then we look at a urine protein creatinine ratio. And again, we can set kind of bands for how mild, moderate, and severe the proteinuria is, just based on the urine protein creatinine ratio. And again, IRIS gives us kind of very clear guidelines as to what we should be doing with particular levels of proteinuria and what therapy we should be instituting. So if urine protein creatinine ratio is greater than 2, then straight away they'd be thinking of ACE inhibitor therapy plus dietary protein restriction. The rationale for the ACE inhibitor is that if we can lower that pressure gradient we talked about in the glomerulus, that's going to help from the point of view of reducing the further damage to the glomerulus and help the glomerulus to continue to function and not just expand exponentially the amount of protein that's actually coming through. And sometimes we'll use low-dose aspirin in order to try and limit the inflammation in the glomerulus that can be associated with that hypertension as well. So again, IRIS can translate very directly from a lab measurement into a therapeutic plan. And again, proteinuria we know is of prognostic significance. Do ACE inhibitors make a difference in proteinuria? Yes, they absolutely do. This is an example from the Forticor study that was published a number of years ago, looking at survival times dependent on whether severely proteinuric animals had ACE inhibitor or not. And you can see, I think it kind of speaks for itself, that if they have the placebo, the survival time is a fraction of what it is if they're effectively treated with ACE inhibitors. So this really works. Urine sediment, all sorts of things we can find. Renal tubular casts to tell us about active renal tubular damage. We can find crystals, we can find leukocytes to indicate, this is where I was talking about active and inactive sediments. We can find red cells, or we can find bacteria. And just looking at the amount of time we have left, I'm going to just very quickly skip through this. So renal tubular casts, the hallmark of active renal tubular damage, this tells you the kidney is being destroyed now. And so we need to look for an underlying cause. They don't survive well on transport, so often it's best to look at these yourself. Or alternatively, you'll need to fix the sample simply by adding a couple of drops of buffered formalin and send it into the lab for cytology. They may not survive on a normal wet deposit. Crystals, the only crystal I really want to mention here is this particular one with the kind of characteristic coffin lid shape that's being pointed out on the arrow. This is calcium oxalate monohydrate, and this is pathognomonic for ethylene glycol poisoning. So if animals have ingested antifreeze, or you have a suspicion that that's the case, look in the urine as fresh as you can and see whether you can see these crystals. If you're not sure, send them in and we can have a look. Urinary tract infection. Certainly we've already recognized that this is a risk factor in renal disease, and it can occur without any leukocytes being present. So really the only way to be sure is to culture the urine, and when you do culture the urine, it should be on a cystocentesis or a catheterized sample. And I put it in the bottom there, if you can, combine it with cytology, because sometimes you'll find the bacteria may be there, but for some reason they won't grow, and if you get a negative culture on its own, you won't be able to identify the fact that there is in fact infection there. This is a kind of classic example in cats where they quite often don't throw leukonuria, and we can see this is from a cat who's in renal failure, and we know that renal failure is a risk factor for the development of urinary tract infection. And the only way that you'll pick up there is infection there is the fact that if you culture the urine, you can see there are large numbers of the coliform there. It's a pure growth, highly significant numbers. And we do know that this is deleterious to renal function. We need to address these infections and clear them up. The other thing, just very briefly when we're talking about cats, you're all probably aware now that there's an increasing incidence of urinary tract infection with age. We used to think that was uncommon, but it's now clear that it is relatively common and increases with age. And the other thing is, be aware that if you're using the dipsticks that involve a leukocyte dipstick, cats will give you false positive results. They contain an enzyme naturally in urine, which is an esterase, that is the enzyme that will actually work with the stick. So don't ever trust the leukocyte dipstick test in cats. Mentioned briefly about cytology. You're going to send it in. You do need to fix the urine. So here we are with an unfixed sample where I can tell you there are bacteria there, but I cannot tell you what this mush is here, the pink stuff. But as soon as you fix it, just simply by adding a couple of drops of buffered formula into a little aliquot of your sample, you find the cells are retained, and we can clearly identify that these are neutrophils here that are there. So we know that there's this infection that's actually present here, not just all of this inflammation here along with the infection. And it makes a world of a difference to urine cytology. So can we fix it? Well, yes, we have to. I apologize for showing that image at this time of night. Okay, basically, when we're looking at our cases, we need to investigate for primary causes of renal disease, and we need to exclude pre- and post-renal changes if we're going to make that first call of we think this animal has renal disease. And by primary causes, I'm thinking of, is it having drugs which can damage the kidney? Is there an ongoing active infection that we can actually address and deal with? The second thing we need to do is to establish baseline data so we know where we're working from, and we need to say to clients that it will involve multiple samples. You can't do this just on a one-off sample, so that they need to understand that we're going forward on a serial basis. And we're then going to stage the renal disease by looking at the creatinine concentration, the degree of proteinuria, and the blood pressure, and for our purposes we're going to critically also look at the phosphate as well. And we're going to check for these systemic sequelae we've talked about, like hypertension and renal secondary hyperparathyroidism, and then we're going to institute our therapy and monitor. So in terms of what tests are you going to need to run on a sequential basis, our view is do a full blood count. These are the chemistries you need, and on the urine you need the whole Monty here, you need the specific gravity, the dipstick, and you need a urine protein creatinine and a deposit, because you can only really assess the urine protein creatinine ratio if you know whether there's an active or an inactive sediment present there. And that's the standard panel that we include what we call an IRIS renal profile. And unashamedly, I put the price on here because it seems to me that in these economic times, we have to be realistic about what we charge, what we all charge in relation to maintaining these cases. We know the insurance is going to run out, and we know that we want to make sure that these animals continue to receive appropriate treatment. So we've priced this very much in order to try and be able to meet the requirements of IRIS, give them that quality care, but not at a price that's going to make it unaffordable to the majority of people. And then we need to consider, are there any add-on tests that we need? Do we need a culture on this sample? And if so, it should really be by cystocentesis. Are we going to need a cytology to go with that? Obviously, we discount both of those when they're incorporated in that panel, but I think you'll find all the labs will do something along those lines. Do we need other specialized tests? Like, do we need to be doing fractional clearances, or do we need to do PCR analysis for leptospira or something like that in a more acute situation? So have a think about what's going to be your protocol for managing these cases longer term, and what's the panel going to be. And from an interpretive point of view, I just want to make the point that as time goes on, we can now start to build up an individuals database and use it as its reference interval against itself. And I think that's a very important concept for the future, is like an intra-individual reference interval, and then see which are the more significant abnormalities. You've seen already, I think that can add a lot to what you're actually looking at. And in some cases, we're going to use these clinical decision limits that are not defined by the reference interval that we give you at the laboratory. They're simply established on the basis of clinical research, and I think they can be very useful as well. You need, when you're doing this, to consider analytical consistency. You don't want to be jumping from your in-house system to your external system. I think you need to set a plan for these and say, who's going to do this work and where are we going to do it? Are we going to do it ourselves, or are we going to send it out? And then you have a consistent basis where we can adjust the therapy based on these results. If you're using IRIS, and together with the clinical findings and the owner, you can find a package that's going to work for each individual and tailor that. Okay, so in practical terms, we manage the renal disease by defining the stage on these parameters. We institute specific therapy, and then our renal protective therapy in terms of ACE inhibitors, phosphate binders, and blood pressure control. Okay, that's just a review if you're wanting to look at individual therapies and see how they're working and what the data is to support the things that I've talked about this evening. And most importantly, getting the owner on side. And if you haven't already, I think Anthony has already mentioned Sarah Caney, but I would certainly reiterate that her website and these books that she produces for owners are invaluable. And I've just popped those on on this last slide, just to show the catprofessional.com is Sarah Caney's website, very useful, and I've also given you a couple of other references there. The last one, Feline CRF, incidentally, is invaluable for owners. It's really an owner website rather than a veterinary one. Okay, thank you very much indeed.
That's great, Nick. Really enjoyed that. Fantastic content, and obviously delivered it in such a nice way as well. Few questions I think that people are asking. You're very fortunate, Nick. I was doing the Royal College Hustings webinar on Tuesday, and I was given very strict orders, 3 minutes per speaker, and I did have to mute a few people. So I'm feeling very tolerant today. I was enjoying the talk so much I didn't have to mute you mid-flow.
Okay, thank you.
I know we've got quite a few people on the line.
Yeah, I'm fine. I'm happy to take questions, or if people want to do it afterwards on a chat thing. I don't know whether you do that now.
No. I mean, if people want to stay, they can stay. I'm more than happy to carry on for a bit. Just before we do that, the webinarvet.com/RCBS-webinars, probably tomorrow, maybe Saturday, we'll have all of the prospectuses of all of the speakers. They were all allowed to speak for 3 minutes. We had over 100 vets on the call. Obviously, I think it went really, really well, and I'm just encouraging you out there, if you haven't already voted, go and have a look at that, and then do cast your vote, because we can't complain about the Royal College if we have no part in the process of voting for people. So do have a look at that. And the whole sort of area of kidney disease I'm very interested in. We did, Nick, a very good series sponsored by Novartis.
Yes.
Again, the webinarvet.com/Novartis-webinars. Sarah did 2 hours, spoke a lot about iris, spoke about some of that stuff as well. So if you do want to indulge in more kidney CPD, do go to there.
Yeah. Can I just add, by the way, I'm
yeah,
going
sure.
to take the PDF of all of the slides that I've shown, because I realise that's a lot of information that I've thrown out there in a very short period of time. So if anybody wants to, in a couple of days' time, if they come to the CTDS website, then I'll actually put that up there, and you'll be able to download that if you want. So you'll
that's great.
well,
that's kind.
Yeah, that's. Just come to us at ccdslab.co.uk, and then it'll be under news, and then it'll just take you straight there.
Great. Obviously, I know that we've got quite a lot of platinum members on today, but we do have, I think, some of Nick's clients as well. So do look out for those Novartis webinars, Novartis-webinars after the webinarvet.com. We also do a free sequence 6 hours of CPD, which is free for you to look at. Obviously, we do have a paid membership. But one of those webinars is on feline hypertension, again given by Sarah Caney. Yes, I can recommend her books. They're very good. So catprofessional.com is a good site to go for, not only for vets, but these are, particularly more so for pet owners, because I think it's quite a complicated disease, and I think the more that we can get the clients to buy in, the more they'll understand the need for frequent monitoring. Would you agree, Nick?
Yeah, I mean, I think this is essential. We now have something where, I mean, all we've talked about there is basic blood tests and urine tests that anybody can do anywhere. You don't need to have highly specialized equipment. And I think now we're in a situation where, well, my personal view is that an awful lot of this could be taken over by nurses and run as renal clinics. To cover a lot of this stuff, and just to reiterate a lot of the stuff that, the importance of those things. And that's why I like that feline CRF, because it really explains it very nicely to the owner, and they can see that it's not anybody trying to pull a fast one on them and flog them a special diet.
Yeah.
This is absolutely integral to keeping the cat well.
And I think it's so nice because, you are obviously, as you mentioned, slightly longer in the tooth than I am, but certainly I remember when I first qualified, and this skeleton would be brought into you, and they would say, we didn't want to bring it in any earlier because we knew you would put it to sleep, and you'd answer, well, you've given me no bloody choice now, how do you bring the cat in like this? And there really is no excuse for that now. We can do so much more. We understand the disease. I think it's great.
Yeah, I was going to say, I remember, I mean, again, being so long in the tooth, I remember the launch of pills in the UK. Yes. I went to a meeting in London, and I was just gobsmacked that suddenly here was something we could do that was going to make renal failure cases really better, rather than just giving them anabolic steroids. And to be honest, I was so impressed I went and worked for them. I thought this is absolutely so revolutionary. And when you actually see the clinical impact, well, everybody now sees it as a kind of day-to-day thing. But I still think there's a huge issue with compliance. I just hear it all the time. People get worn down by, clients coming in saying he doesn't like it. And I think we've got to find some tools to actually get them to take that on board, because if they do, it's going to make a huge difference to the outcome. There's no two ways about that.
Well, I remember the study that was done, and you alluded to there, and it just doubles the survival time, which is just so significant, isn't it? Yes. So important.
I was also involved in the clinical trial for Forticore, the big study. And it was unbelievable, because the conclusion they came to was that it was obviously very good for the proteinuric animals, as I've shown you there, but we just saw some of the azotemic animals, chronic, stage 2 disease, and sometimes even stage 3 disease, that became non-azotemic when they were put on an ACE inhibitor. I think it's just fabulous. Stuff, in the right individual, and as long as it's monitored so they don't become dehydrated when they start taking it and things like that, then it's a fabulous drug.
Yeah, I mean, we've just got so much we can do now. We'll move on to questions now. I've got one last thing that I want to just bring up. Nick is coming back in early May with Adam Bell, who's is a medic at Calder Vets in Yorkshire, and they're going to come back and do some more sort of. I think we're going to do bone marrow testing, aren't we? And
we're going to do how to take a good bone marrow aspirate sample, and I'm going to sort of show you around what I'm actually looking for within the bone marrow, so that you can see what the kind of benefits are and what we can actually get out of a bone marrow sample.
And then another webinar we're doing alveolar lavage as well?
Yeah, BAL. Yeah, on exactly the same basis. Adam's got some very nice shots of how to actually do it, very practical stuff to consider, and really kind of takes it step by step through. And then I'll show you again what we can get out of it from a pathology point of view. I think when we presented this before, it seems to have gone down quite well. So yeah, we'd be delighted to have you join us.
No, that would be super. So they are coming up in early May. They're obviously for clients of CTDS as well as obviously for the Platinum membership. So they will be coming up on a Thursday, 2 Thursdays in early May. So do look out for those. We're just getting all the bits together before we launch them onto the site. And then one last thing, remember the Platinum members who are on, you've got still about 10 days, 10 days until the free month for your friends goes. So if you've got a colleague or a friend who you think would like the Platinum membership, then do just let Catherine know. We have quite a few people coming in, and we're giving you a free month to offer to the friends, just so that they can test the service, which, I think we all enjoy coming on for our Thursday nights, and then obviously all the recordings that we have. So there we go. I think that's everything. Twitter. Yeah, follow me on Twitter, Anthony Chadwick 6. I'm becoming a tiny bit addicted by Twitter, Nick. I don't know if you've got a Twitter feed.
No, I don't do it. So
come on, Nick, get into the 21st century. Sorry, I've been having too much of a go of you today. No, it's been fantastic talk, so I do apologise. Get into trouble.
No, I enjoyed it actually. That was good.
Right, great. Now let me just see what we've got coming up. Yeah, somebody was just asking how to fix the urine slide. What's your recommendation there?
Right, it's very simple. For the technique I use is you simply take 2 drops from your normal histology pots, because they should have in them 10% neutral buffered formal saline. Take 2 drops, fill up a normal EDTA, which is usually a 1.1 or a 1.3 mil sample, EDTA sample, and just gently invert the urine, making sure you're taking a well-mixed sample first of all, so whatever you collected in, mix it first, so whatever you put into that EDTA pot is representative of what you've collected. That's the first thing. And then when you fill it up to the line, either at 1.1 or 1.3, depending on the size, just add those 2 drops of buffered formalin, and that will be just enough to hold the cells together, as you can see in the slide that I showed, but it won't kind of make them close up into a little tight ball. And if you put too much formalin in, they'll just what we call round up. It'll be impossible to see into those cells at all. So 2 drops to 1.1 mil is perfect in our hands anyway.
Now, Nick, just to be clear, we're obviously not spinning the urine down. It's just ordinary urine that you've got there.
No, because when it comes into the lab, we use a sort of more sophisticated spinner, a thing called the cytocentrifuge, which is just basically where we can use a bigger volume and we're just much gentler with the cells than actually whapping them through the centrifuge. It runs at about 1500 RPM and it's very gentle on the cells indeed. So basically, you don't need to spin it down at all. You can, if you like, also send us some spun down deposits that are unstained. You just spin it down and just smear it out on the slide and let it dry. That's very helpful too, actually, and we like that for crystal identification as long as you can do it while the sample's still warm, because then we know if we're seeing any crystals, they're genuinely representative of what was there in the animal, not something that's formed afterwards. So you can do both, and I mean, we just look at all of the material, under the same fee, and as far as I know, all the other labs do exactly the same thing.
Okay, that's useful, because I tend to spin down and then just take, obviously, the sediment at the bottom and put it on a slide, but obviously do that, but do the urine thing as well.
But do the fixing the whole urine,
Yeah, great. Jamin is asking to see the pre-renal azotemia slide again, but Jamin, what I would suggest is, obviously it should be up on the site in the next day or so, but also go on to ctdslab.co.uk to get the PowerPoint, but obviously the recording will be on our site. But I think obviously anybody who is not a member of Webinar Vet, the way we've set it up, you should be able to see the recording as well. So do come and have a look, and if you're having any issues, problems, get in touch with Catherine at the office and she will happily help you. Mark is saying, thanks for a really good webinar. So if the USG is between 1.002 and 1.006, we should essentially be looking for a different cause to the PUPD, and it's definitely not the kidneys.
Absolutely right. That's absolutely correct. Yep. So the differential list is quite short. It's usually either an E. coliform urinary tract infection, it might be hypercalcemia, it might be Cushing's, it might be a primary polydipsia. There aren't really a whole lot more differentials, and it ain't renal. It's not renal.
Yeah, diabetes and insipidus.
Diabetes and insipidus,
yeah. I'll give Jill's full name here because I think she went to vet school with you. Jill Malink Davidson. Thanks, Nick.
Oh,
a long time since vet school, so there you go.
So.
Ejaz is saying, any facilities for dialysis in the UK? Any dialysis work going on in animals?
I think people do not really see dialysis as a long-term option. I think renal transplant is probably the only way we can go, because they simply, just because of the physical constraints of having to lie still plugged into the dialysis machine 2 or 3 times a week, I don't think it's a practical option for pets. So I think it's if we're at that stage, I think it's renal transplant or bust, to be honest with you. So I'm not aware of dialysis facilities being set up anywhere in the UK for that reason.
Yeah, I would agree with that. There were a couple of people who had a bit of trouble with the sound. If you're still on, I think we've got a very good recording, so it will obviously go on the site. And I'm just sorry that you've not been able to hear as well. It can sometimes happen. This technology is good, but it's not perfect yet, unfortunately. So hopefully those of you who've maybe had a few difficulties, it will be on the site very quickly. Just a very quick question from myself, Nick, and then I think we should finish. It's interesting, isn't it, this whole sort of delicate balance between chronic kidney disease and hypothyroidism. You know, you treat the hypothyroidism, you unmask the kidney disease. Have you got any thoughts on that, or anything else you wanted to say?
I think there's 2 things that have happened. I mean, I think everyone is considerably more aware of this now, and I think it's now become good practice just to continue to monitor renal function continuously, really, when you're doing medical therapy. I think the other thing that can be helpful is if the T4 is below the limit of detection. You know, if you're getting a very low T4 result, or so low that you can't measure it. You know, people conventionally used to think, well, that's fine, you know, we've treated the hypothyroidism, but I think we're now going to be slightly more cautious about that, and we're probably aiming to have a detectable T4 level. And you can also now measure TSH in cats, and if we actually measure endogenous TSH and find that's high, that's probably a good indication to us that we should be backing off a little bit on our thyroid medication. Otherwise, we're potentially slowing everything down a little bit too much, and renal tubular flow is going to start to deteriorate, and we potentially again can just unmask further any pre-existing renal disease. So yes, measure TSH if your T4s are undetectable, and/or think about backing off the dose so that you're just maintaining a low detectable T4 concentration. I think that's probably optimal.
That's great, Nick. Again, fantastic webinar. I've really enjoyed it. You know, kidney disease is so important. We see so much of it, especially in cats, and it's been a great run through, particularly looking at all the pathology, which you know, I think I've certainly learnt new things. So it's to mix metaphors. You can actually teach an old dog new tricks, obviously.
Okay,
Nick, thanks again. Looking forward to seeing you in May with the next 2 webinars. Very briefly before we finish, next week is Maundy Thursday. We've got a recorded webinar that was given in South Africa on bearded dragons. Supposed to be really, really good, so do go on for that. The following Thursday is BSABA. I'm hoping that many of you will come down and see us on the stand. Nick, do you have a stand out there?
Yes, no, I don't have a stand, but I'm coming over on Friday.
Going to be around, so come over and see us at the stand as well.
Yeah, we'll do.
Take care. Thanks, Nick. Thanks, everyone. See you soon. Bye-bye.